Thank you for this introduction, and thank you to the organizers for inviting me here. It's a great pleasure to be here in Hong Kong and sharing this data with you. In this presentation, I'm going to tell you about the work that has been produced by the laboratory of Professor Carlos Simón in Spain, and also from my colleague Xavi Santamaria. They cannot make it to be here, so I have the responsibility to bring the message to you, so I hope that I will be able to do it properly, so let's start. So following with, well, this is my disclosure. Following with the topic of this session, I'm going to talk about stem cells in regenerative medicine in reproduction, but I'm going to jump from germ cells to the uterus. And we study the uterus because we think that it's an outstanding organ, and regardless whether this is ethical or not, this is something that is happening today. So, apart from the uterus, we focus on the endometrium, and to our knowledge, at least to my knowledge, this is an outstanding organ too, because this is the only organ that is able to grow from nothing, nearly nothing, and acquire functional capabilities in only 1 month, and then it's break down, and then start growing again, and again, it acquire these functional abilities, and this is something that can happen around 500 times in a lifetime, or even forever, because medicine and science have demonstrated that this can be in response to hormones. Endometrium can keep cycling even after the menopause. So taking into account that this is a functional layer that is going to be lost in every menses, and that only this basal layer is going to keep attached to the uterus during the whole cycle, it is easy to believe that there's something magical here in this basal layer that is going to promote this endometrium to grow again every cycle. So in this line, in our laboratory, we have studied these potential endometrial stem cells, and we have been able to isolate these side population cells with adult stem cell features. Also, we have shown that these adult stem cells, these side population cells, are able to reconstruct the human endometrium, but not only our group, but also some other groups. For example, this paper is from other group that has observed more or less the same results. And this is this would be the endogenous source of endometrial stem cells. And apart from this, there are also other works that has proposed bone marrow stem cells to contribute to the regeneration of the endometrium. For example, in this study, we have a situation in which bone marrow transplantation was made from a donor to a recipient, with which were HLA mismatch. And after this transplantation, the cells, the HLA from the donor, were found in the endometrium of the recipient. And later on, same results were observed in this work, in which the bone marrow transplantation was performed from a male donor into a female recipient. And after this transplantation, these XY cells by FISH were found in the endometrium of the recipient. So this is another way to contribute to the endometrial regeneration. But well, we have observed that they are different kind of cells, so there are this kind of plasticity in this endometrium to be regenerated by different types of cells. But not only the stem cells are important in regenerative medicine, we also have to talk about the niche in which they are going to grow. Because the niche is going to provide this physico-chemical environment so that the cells can start growing and then differentiating into to reach their final fate. And in the human endometrium, it seems that this niche is here in this basal zone of the endometrium, and specifically in the endothelia, that is in the spiral arterioles. So with this in mind, we started to study some years ago endometrial stem cell niche pathologies, because we think that if this niche is impaired, these stem cells cannot grow, cannot proliferate, and instead of regenerating with endometrial cells, what we are going to have at the end will be fibrotic tissue. So based on this idea, we studied two examples of these kind of pathologies, which are Asherman syndrome and endometrial atrophy. And as all of you know, these are two severe conditions that have very bad prognosis for those women that want to conceive. So what we hypothesize is that maybe using bone marrow-derived stem cells, we can use them as a stem cell source to help these endometrial pathologies to regenerate. And we have chosen these CD133 positive cells because different reasons. First of all, because they are endothelial progenitors, so this takes us back to the niche in which the stem cells have to grow. And they are able to engraft and differentiate to non-hematopoietic cells. Second, because they have been proven to be very safe in both humans and in animal models, so they look to be perfect for this. And last but not least, because there's a commercial kit with CEE mark to isolate these cells for clinical purposes. And this is very important for us because in Spain, or in general in Europe, we cannot use any cell for clinical purposes if we don't have this CEE mark, this approval from the European community. So this also helps us to decide which kind of cells we were going to use for this therapy. So we propose this advanced stem cell therapy for refractory Asherman syndrome and endometrial atrophy. So we will have as a stem cell source these autologous CD133 positive cells, and for the needs we will infuse these cells into the spiral arterioles of the patient. So the study question was, could cell therapy using autologous peripheral blood CD133 positive cells offer a safe and efficient therapeutic approach for patients with refractory Asherman syndrome and or endometrial atrophy wishing to conceive? We designed this study. This is a phase 1 study which has been developed in Valencia, in the Hospital Clínico in Spain. And we recruited 18 patients with the following inclusion criteria. They were patients diagnosed with refractory Asherman syndrome and or endometrial atrophy with implantation failure, between 30 and 45 years old, absent of pregnancy after the diagnosis of this condition, normal liver, heart, and kidney function, absence of any psychiatric pathology, and of course, beta ACTH negative. This study was sponsored by the Spanish Ministry of Health, and we use these methods that you can see here to obtain these CD133 cells. We mobilize peripheral blood of the patient by injection of granulocyte colony stimulating factor. Then, through the process of apheresis, we isolated these CD133 positive cells that were injected back to the patient in the spiral arterioles. So the design was after menstruation, if any, the patients went to hysteroscopy to grade the stage of the pathology at this before the transplantation, before the therapy. Then they were mobilized, the apheresis was done, and then they received the autologous transplant of their own cells. The patients were monitored for more or less 2-3 months to check whether there was any improvement in the uterine cavity after the therapy, and then they went to ART. Before going on with the results of these experiments, I would like to point out that in parallel to this cell therapy, we also did an animal model and to check the engraftment of these cells. And we did this because in human we are not allowed to label the cells that we are going to transplant, but we can do this in an animal model. So a small portion of these cells that we obtained from the patients were labeled with SPOs, and they were injected into an animal model using 2 different models, even in the intrauterine injection or also in the tail vein injection. And we wait for a long time and then check whether these cells have been engrafted or not. What we saw is that the results that other groups have previously published were confirmed because we saw that these cells were engrafted close to the blood vessels in the endometrium. So the niche is there. And following to the human, this is a reconstruction of the radiologist image. Here you have the results of the Asherman syndrome. These are the patients that went to this cell therapy. So this is this history of these patients, the maximum endometrial thickness before the infusion of the cells, the number of cells, the million of cells that we use for the transplantation, and the results of the hysteroscopy. In the first column, you can see before the transplantation, and this is the evolution of these patients after the transplantation. As you can see, all of them improve the hysteroscopy in the uterine cavity. Then maximum endometrial thickness after the cell therapy, which was increased in all the cases, and the pregnancy outcomes that we will go back to the pregnancy outcomes later on, but you can see that there are some pregnancies. The same for endometrial atrophy patients. There were only 5 patients with endometrial atrophy, so this is the history. Maximum preoperative endometrial thickness, which was very low. Number of cells infused, and the hysteroscopy data, which shows that all the patients recover a normal endometrium except for this patient, patient number 14, that didn't recover any future. Maximum postoperative endometrial thickness was improved again in all the patients except of patient number 14, and the pregnancy outcomes. So, this is a schematic so that you can see which was the difference of the endometrial thickness before and after the treatment. This is the average numbers. And this is a specific example of endometrial thickness and endometrial volume before and after the infusion of the CD133 positive cells. And when we started to look into detail into these tissues, what we observed is that after 3 months of the infusion of the cells, we saw an increase of the major blood vessels in the endometrium of the patients that were transplanted. However, this increase went down again after 6 months of the treatment. So we started to look into all the data, and we observed more or less the same tendency when we analyzed the recovery of the menses of these patients. These are the menses duration and the pads per day before the treatment that were increased after the treatment. This is 1 month after the treatment, 2 months, and 3 months. And as you can see, there's an increase at the beginning of the therapy, but it declines afterwards. So what we thought is that maybe there was a tendency to hypomenorrhea at 6 months, and we decided to make a modification in the protocol and to advance the time of embryo transfer to the 4th month after the infusion instead of the 7th month that was planned at the beginning of the experiment. These are images supporting this data. This is a patient of Asherman syndrome, the control before injection and 3 months after injection, 6 months after injection, and 1 patient with endometrial atrophy, the hysteroscopy, 3 months after injection and 6 months after injection. Regarding the incidence, we didn't find any side effect so far. 2 patients were excluded from this study, one of them because she had very poor CD133 mobilization, the other one because has no peripheral venous access. And regarding the reproductive outcomes, we had 3 spontaneous pregnancy at the 2nd, 4th, and 22nd months after the cell therapy. 14 embryo transfer were performed, and 7 of these patients become pregnant, so pregnancy rates of 50%. And from the 10 pregnancies, 3 spontaneous and 7 IVF pregnancy, we had 2 biochemical pregnancy, 2 clinical miscarriages, 1 ectopic pregnancy, and 5 live births survived. So 38.4 live birth rate. Here you have the images. I like this slide very much because it's images from the babies that were born, 2 different examples. And with this I will go to the take-home message. First one is that advanced cell therapy using autologous peripheral blood CD133 positive cells offer a safe and efficient therapy for patients with refractory Asherman syndrome and or endometrial atrophy wishing to conceive. And this is based on our results. The first objective that we have at the beginning of this work was the reconstruction of the endometrium, which occurred in 15 out of 16 patients. And this was assessed by the restoration of the menses, endometrial thickness, the histology, major blood vessel count, and hysteroscopy. But still, the engraftment was not permanent, so this is something that we have to still improve to see which is the best scenario and the best timing to do the IVF after the therapy. Our second objective was to test the functionality of this new endometrium by attempting to conceive. We had spontaneous pregnancies, and we have also some pregnancies through ART, and 5 babies were born after the therapy. So this is very good news, but still has to be improved because we also had some biochemical pregnancies, clinical pregnancies, and so on. So still a lot of work to do here in this site. And in the animal model, the injection of humanized POs labeled cells into a murine model of Asherman syndrome confirmed the engraftment around the endometrial vessels. This engraftment was very low, but we think that maybe it's because of the heterologous model, but induced the proliferation of surrounding cells, and we think that is through a paracrine effector. So this is the phase 1 study that is now completed. These results are already published, and we are now going into the phase 2 study. This study is called ENTIRE, for endometrial tissue regeneration, and the objective of this phase 2 is to define the dose of the cells and the safety of these cells. We are going to perform this study in 20 patients and will be sponsored by Genomics. And this is the scheme of the design that we planned for this study. As you can see, it's very similar to the one that I showed you before, but the only difference is that we are going to introduce the endometrial receptivity analysis and the uterine microbiota assessment before and after the infusion of the CD133 cells. And before the end of this presentation, I would like to share this information with you because this is something that we are very proud of, and is that we have recently received the orphan drug designation for this kind of therapy, for the use of CD133 positive cells in the treatment of Asherman syndrome by the European Medicines Agency. And this is something that has required a lot of effort from our group, and we are very proud because we think that we are one step closer to treat those patients that come to our study looking for help. So, as I said before, this is the work of Professor Carlos Simon and Xavi Santamaria and their groups. So I would like to thank, first of all of them for their excellent work, and all the collaborators that has been involved in this project, in the clinics, and taking care of the mothers after the pregnancies and in the deliveries. And thank you, all of you, for your attention.